Well, first of all, welcome to all of those folks who are tuning in tonight. We're thankful to have you with us. This is our third year in a collaboration with AdMeTech and Dr. Stern, and I represent and others on the panel with the NAACP Cambridge branch. You'll meet our president, Mr. Ken Reeves, as well as some of our other panelists, Dr. Feldman and Christina Deal Conright, who will join us tonight for a conversation about prostate health. And I just want to say, as a community member here in Cambridge, I want to be thankful to the collaboration with Dr. Stern and AdMeTech. As I said, we're in our third year with Dr. Stern and her organization, and it's been a stellar collaboration, one that allows us in Cambridge and abroad in the greater Boston area to really talk about an important issue of men's health, which is prostate cancer and prostate health. I'm very thankful also to Dr. Stern's organization for making sure that we stay organized. And no matter what happens through the state funding and all the tumultuous world of public health, Dr. Stern makes it possible for us to get together. And so without further ado, I just want to thank everybody and introduce the Cambridge branch president of the NAACP, Ken Reeves, who's going to provide some of his own personal testimony and experience around our relationship with the AdMeTech Foundation and his own personal battle in the area of prostate health. Mr. Ken Reeves.
I thank you, Mr. Richard Harding, who is also the first vice president of the Cambridge branch of the NAACP. So he is the wind beneath the wings of our branch. I'm not sure everybody knows what the NAACP is. So very briefly, we are a 116-year-old civil rights organization, the oldest in the U.S., and we like to think the most effective. And we have 2,100 chapters across the country. We call them branches, representing some thousands of people who are devoted to change in the American context, equity, and justice for all. And the questions of health disparity are at the front of our agenda, and that's how an NAACP program could happily join with AdMeTech to do health advocacy, particularly directed at men of color, because in our title, we are the National Association for the Advancement of Colored People. So in that rubric, we would include the men of color. Mr. Harding mentioned that we have a men of color health arm of the city's public health office. He didn't say, he suggested it fell out of the sky. It didn't. We kind of took the question to the public health leadership in the city of whether or not the Black male life expectancy in Cambridge mirrored that of the U.S. at a time when that was only 68 years. And that was a time more than 30 years ago now. So we have been in these waters a very long time, but we do welcome our partnership. To be very brief, I will say that my introduction to AdMeTech was really an interesting journey because I had a bump that I was afraid I should stop scratching. So I went to see if they could remove this bump. And the doctor said, well, why don't you have a blood test? After diagnosing that the bump was benign. And I had the blood test, and suddenly I was on this A1C journey and learning what my higher numbers meant. And before you know it, I was having to choose. I was diagnosed with prostate cancer, and suggested that I might also contact other men in my family. And I contacted my brother, who's 3 years older than me. And he went to his doctor. And of course, he also had prostate cancer. So this hereditary thing or runs in families is a very real thing. But where my journey took a turn is I chose to having a procedure called CyberKnife, which is at that moment was the cutting edge technology, and it also was fewer treatments. And I did well with that for a year, but in year two, at my annual checkup, A1C number was high and couldn't tell why. And I went to a long series of tests here, thither, and yon, only to find out that the test I really needed was only available to me at Sloan Kettering in New York. But along this journey, I was explaining to another NAACP president, Juan Cofield, who said, "You know, Ken, sounds like you are lost in the system. I have to introduce you to Dr. Stern, who is with AdMeTech Foundation, who is partnering with the regional group of the NAACP." And I was introduced to her, and she was the only person who was able to move the mountains necessary to get me to Sloan Kettering. So I will always be indebted to her. But what I learned from all of that is what AdMeTech is able to do is to offer to the men of color of Cambridge the first quality health care access that is just not available to everybody. You got it, when you know, and when you don't know, you don't know. And so to have a partnership with a program who can get our guys from the Cambridge Mental Health programs and our guys from the NAACP related endeavors to where they need to go. Now, just so you know, we do some not infrequent business with Dr. Stern in referring people who come to us or who happen to be in our lives to say that this is someone who is going to need special guidance and or care. So I thank her for all of her good assistance. And I'm so pleased to have been able to suggest that Dr. Christina Deal Conright be a part of this evening's program, as I am in the program which she is overseeing, which has to do with, again, I'm all about Cadillac health care for men of color. I'm not going to tell you everything her program does. I'm going to let her do that. But I would say that I'm glad that we can bring to this collaboration information about other programs that we can review and think well of. And I'll just end by saying, Mr. Harding, whatever program you're in, that's my program too. So we will always be running the best program because Mr. Harding is the best Pied Piper of men of color I've ever experienced. He is able to inspire men of color to pay attention and follow his lead on health issues, and that is a rare quality. So thank him and thank our branch, our secretary, who was City Councilor Aisha Wilson, is here with us, as well as our second vice president, who is Mr. Stephen Brown. So we at the Cambridge branch are on fire for help with prostate cancer in our community. Thank you.
Thank you, Mr. Reeves. So I want to introduce, without further ado, Dr. Adam Feldman, MPH urologist at Massachusetts General Hospital. He's assistant professor of surgery at the Harvard Medical School and director of the combined Harvard Urologic Oncology Fellowship. Dr. Feldman, welcome. The floor is yours, and I'm just so honored to have you with us tonight. Dr. Feldman.
Thank you, Mr. Harding and Mr. Reeves, and thank you so much for welcoming me. And thank you, Dr. Stern, for inviting me to speak. It's an honor and a pleasure. I apologize that I'm in scrubs. I came in a shirt and tie and jacket, but I finished a little while ago, and I'm sitting in a back room in the OR here. So I apologize for that.
You're forgiven, Dr. Feldman. Forgiven.
Thank you very much. So yeah, it's really, what I wanted to, I'm a urologist. A urologist is, and what's called a urologic oncologist. So I take care of a lot of men with prostate cancer. And it's a subject that's very important to me, and want to go through a little bit about what how we screen for prostate cancer, sort of what treatments are for prostate cancer, what are new treatments. I think if I, looked at the calendar, we have maybe about 15 minutes or so. Is that correct?
Yeah, I think we're right on schedule.
Great. So what I'm going to do, if that's okay, I'll share my screen. I have some slides, if that's okay with everybody. What I want to talk about is recent advances in screening and diagnosis and treatment of early stages of prostate cancer. So just to start and give a little background information, prostate cancer is the most common cancer in men, other than skin cancer. There's over 300,000 cases expected in 2025. It's the second most common cause of cancer death in men as well, with almost nearly 36,000 cases, deaths of prostate cancer in 2025. And about 1 in 8 men in the United States will develop prostate cancer. So if we look at how, when we think about the diagnosis of cancer, when people are diagnosed with, or found to have cancer, we think about, are they, is the cancer localized within the organ of origin where it comes from, or has it spread to other areas of the body? And fortunately, most of the cases of prostate cancer that are diagnosed, about over 70%, are localized or confined to the prostate at the time of diagnosis. And then you can see that there still are, a lower proportion, but cases that are detected when they're detected, they have spread to other areas of the body. And I'll get back to that. That's an important point as we talk about screening. So first of all, I'm just going to back up and say, what is the prostate and where is the prostate? Okay, so this is just a picture of the anatomy of a man, of a man's pelvis. And this is sort of sliced, down the middle. You can see that, obviously the penis and the testicles and the scrotum is very familiar. This is the rectum and the anal canal. And then but the bladder sits right here. So the urine, is stored in the bladder, then comes out through the urethra, and the prostate sits right underneath the bladder. And that actually explains why, and the urinary tract goes right through the prostate, and explains why many men have urinary symptoms where they have to, they have weaker stream, or they have to, go to the bathroom more frequently as they get older. And that's mostly not because of prostate cancer, mostly because of benign or non-cancerous enlargement of the prostate. And so that's why many men get those symptoms. But the actual role of the prostate and the job of the prostate is that it helps, it's a reproductive organ. So it helps, make the ejaculate fluid, that are important for reproduction. So screening for prostate cancer is done in 2 ways. Often people will do what's called a digital rectal exam. It's a prostate exam through basically a rectal exam that you can feel the back of the prostate. You're looking to feel if you feel any abnormalities or any areas that are firm or concerning. And then the other way that we screen for prostate cancer is with a blood test called PSA, or prostate-specific antigen. So it's actually a protein that's made by the prostate. It's measured in the blood. It has a role in reproduction, and it's measured again. It's a blood test. This is a little bit of a cartoon, but should we use PSA? And the reason I say that is because there's been some controversy over the past several years about should we be using this blood test to screen for prostate cancer. Okay. And the reason, I'm not going to show all the data, but I'll just sort of talk about it and explain that the reason it's controversial is because it's not a perfect test. And there were a couple of studies, clinical trials, that looked at screening for prostate cancer to see if there was a benefit. And it's a little bit, I would say some of the data can be a little bit confusing in how to interpret. And so there were 2 trials. One was a trial in the United States, and then one was a trial in Europe. And the trial in the United States, actually, it probably wasn't designed perfectly, because ultimately what it ended up testing was PSAs every year compared to PSAs every once in a while, sporadic PSAs. The trial that was in Europe was actually a little bit more rigorous. and really said, assessed PSA annually versus no PSAs at all. And that actually did show a mortality benefit in terms of helping to prevent prostate cancer deaths. But what it also showed is that you actually needed to treat a lot of men in order to prevent deaths of prostate cancer. And I'll get back to this point in a minute, it didn't take into account that there actually, because it was done a while ago, that now today, there are many cases of prostate cancer we may not need to treat, and we do what's called active surveillance. So the U.S. Preventive Services Task Force in 2012, based on these trials, and I would say some differences in interpretation, recommended not to do PSA testing. Okay, and so what happened after that decision was made in 2012? And what happened was, these are data that actually look in the 5 years after this decision was made. And actually, there have been similar things that have been done in the past for breast cancer. And, it's not that people are trying to do the wrong thing, people are trying to do the right thing for populations. And but what was identified was that after that change and the recommendations, that we actually saw a lower number of men presenting with localized prostate cancer, and then an increase in men presenting with prostate cancer that has spread to either lymph nodes or to other parts of their body, such as bone or other areas. And so what ended up happening actually is that then in 2018, after seeing these things, then the U.S. Preventive Services Task Force reversed that decision and said this should be a decision between your provider, your primary care provider, and the patient to talk about the risks and benefits of PSA testing. So what we recommend is, it's really important to mention that, because when I have conversations with patients, some people, or even friends and people I'll know, they'll say, my doctor said we don't do PSA testing anymore. And I would say that it's very important to do prostate cancer screening. We typically recommend in a normal a patient who does not have a higher risk, to start screening at age 45. And then at men who are at higher risk, and I'll get to some of those groups, but men who are at higher risk, people who have a family history of prostate cancer. Black men have a higher risk of prostate cancer. We think it's a little bit complicated, and there's a lot of people doing good research and trying to understand that. But to think about doing a PSA test at age 40. So the blood test is not perfect. We know that. There are a number of reasons that people can have an elevated PSA. I'm not going to go through all of them. But we want to use PSA in a sensible way. So we think about PSA adjusted to someone's age. We use PSA adjusted to the size of somebody's prostate, because the normal prostate makes PSA just as well as prostate cancer. And we always, if we see an elevated value, we repeat that, because we know there can be, PSA can have variations. It can be variable, especially in men with larger prostates. And so we want to be very thoughtful about, how we assess a man with a higher PSA, and we watch PSA trends over time. There's a lot of other tests out there, and I just show these to really show the names. There's a lot of other blood tests and a couple of urine-based markers that, some people may hear about along the way if they're being evaluated for prostate cancer. And they also are not perfect. And then people now, the approach that we typically use now when we see a man with an elevated PSA is to start with a prostate MRI. Okay. And the reason is, this is actually a graph that looks at the performance of an MRI in detecting prostate cancer compared to some of the other markers or tests, blood tests that are out there, and urine-based tests. And actually, MRI outperforms other tests for detecting prostate cancer, or even showing that there is no, evidence of prostate cancer in the prostate. Okay. Just some images of what does the MRI look like. This is the prostate. MRI actually, it's pretty incredible how what it does. It actually looks at how tissues respond to the magnets, and gives us a very nice image of the prostate and the bladder and the rectum underneath. And it actually then shows, in some cases, can show us, this is a pretty obvious case of prostate cancer. This is the prostate that I'm outlining. And you can see here, there's a nodule or a focus of what looks like prostate cancer. And we see that there are different components to the MRI, including uptake of contrast that's given during the study. So one of the really neat advances that we can do now is that when we do a biopsy of the prostate, we use actually an ultrasound to show us the prostate. It's an ultrasound that shows the prostate from in order for us to biopsy it. We actually have software that we can now superimpose the MRI that's done prior to the biopsy onto the ultrasound, and that way we can target things that are seen on the MRI. It's called a fusion biopsy. It's fusion of the MRI and ultrasound images so that we can make our biopsies more accurate. So this, we really, we started our program at Mass General doing fusion biopsy in 2014. It's really changed in the way and how we can detect men with prostate cancer and how we can assess what types of prostate cancer they have, or I should say, how aggressive a type of prostate cancer they have. In spite of the advance there, MRI is not perfect, and there's what's called there can be some false negatives. And we know that there's also variability in the accuracy of MRI, not just by the technique, but also by the interpretation of images. So, and then the other thing is we know that the false negative rate changes based on the prevalence of prostate cancer within a population. Okay, and that's really important actually, and this leads to there's a very recent study that actually just came out in the Journal of Urology just this year. And actually what this states is that the negative predictive value of a prostate MRI, what does that mean? It means that if you get an MRI and it says we don't see any evidence of prostate cancer, how much can we trust that, right? We know it's not perfect, but how well do we know that really there's no prostate cancer there? And actually, it showed that there's a lower negative predictive value for Black men compared to non-Black men. And what that means is that we have to be mindful of if a man gets a prostate MRI, if it doesn't show anything, we want to be careful about who should we still do a biopsy in to look for prostate cancer. And people like me who take care of prostate cancer, we always know that even if we see nothing, we sometimes will do a biopsy, and we really base that on their level of PSA compared to the size of the prostate. So these are really interesting data that are brand new, and I think important for us to know. And how do you explain that? You explain that there's a higher prevalence of prostate cancer in men of color, and so that's something that makes sense. It actually makes sense based on what we know about the negative predictive values that we see. So can we make things better? Are there other tools that we can use? There's something called a PET scan. It's actually a relatively new type of PET scan specifically for prostate cancer. It uses an agent that goes into the bloodstream, and then you can image that agent. It's called prostate-specific membrane antigen. And so we're doing a study. We're going to be starting a study soon. And we've actually already started. It's an NIH-funded study, and then we're going to do another additional study after that to look at using PET combined with MRI to see if we can better characterize prostate cancer. And we're hopeful that that will help make detection in the future even better, and the understanding of what type of prostate cancer people have even better in the future. So once a man is diagnosed with prostate cancer, then how do we manage them? What are the options? So one option I touched on earlier is active surveillance. And what does that mean? It means that we know that not every case of prostate cancer needs treatment. So we determine that by a couple of things. We determine that by, on the biopsy, how aggressive does the prostate cancer look? Is it low risk? We actually have risk classifications. In most cases of low risk prostate cancer may not need treatment at first. Okay. But for people who do need treatment, then options include surgery, which most surgical cases now are done in a minimally invasive fashion, what's called robotic-assisted surgery, laparoscopic surgery, so small incisions. And then there's various forms of radiation, what's called brachytherapy or seeds, external beam radiation, and it's a very highly targeted type of treatment that can use radiation to treat prostate cancer. And then sort of some area, so I would say an emerging area, and I'll get back to that point in a few minutes, is focal therapy. So with active surveillance, we know it's quite safe for appropriately selected people. The survival is very similar in appropriately selected people. So that's really, I think, an important point. There was a study, the largest study of active surveillance, or what I would say active observation, was actually in England. Now, one of the things, if you actually looked at this, you'd say, well, in this active observation population, there's a slightly higher risk of spread of prostate cancer. And the one thing I would say when you're looking at this is that actually their grouping of, their allowance for active monitoring is a little bit looser than the United States. They're not quite as stringent in terms of, repeat biopsies and monitoring people over time. And actually probably have a few more people who have intermediate risk disease in some higher risk categories than we typically would do here in the United States. But we think it's a very safe treatment. And then, but over time, I would say at 10 years, about half of men, this is a graph of our data from Mass General, about half of men come to treatment over time, okay? And so that's important to know, that active surveillance isn't just, see you later, you're going to do okay. Don't worry about it. We're going to be watching you closely over time, with checking your PSA blood test, doing some repeat biopsies, and watching you very closely. Well, this is just an image of the Da Vinci surgical system that we use. It's a surgical system. There are some other emerging competing surgical systems, which we're excited about, and to do minimally invasive surgery. And really, the rationale for minimally invasive surgery is smaller incisions and faster recovery and less blood loss. There's even other newer robotic instruments coming out where we can make one incision, and then the instruments go as opposed to multiple small incisions, and the instruments go into this space to remove the prostate. And so, there are a lot of really exciting, I think, developments in surgery and how we can make surgery, more comfortable for patients and less challenging for patients. Again, I'd mentioned the PET scan. Again, this is, we use MRI. We use MRI for surgical planning. It helps us guide how we're going to do the surgery, and avoiding other structures that are nearby, and then trying to improve outcomes for men in terms of urinary control after surgery, and sexual function after surgery, and recovery of erections after surgery. It's something that's really important. I'm not going to get into a lot, but those are important conversations to have with men. And then sometimes we'll even use the PET studies to help us identify or target either lymph nodes or areas that are, questionable, that we want to remove during surgery. In radiation, there are a lot of advances, even in the past, in the past 15, 20 years, there are huge advances in radiation to make it more targeted. This is an old sort of version. Actually, that's not even 2D. That's sort of a little more modern, but to where this is sort of the planning for the radiation fields. And now what the radiation oncologist can do is really tightly, accurately target the prostate to try to minimize any potential side effects from radiation. And also we can use, everybody's talking about AI now. There's a lot of AI research or artificial intelligence research in cancers. And what a group has done, and there's a company formed around this, to use artificial intelligence to look at the prostate cancer tissue on biopsies, and to try to help better select people for radiation, and use of other treatments around radiation to make their treatment better. So we're excited about these different ways that we can analyze tissue using artificial intelligence, different ways to analyze what are called biomarkers, or different types of tests that we do for diagnostics. Also, there are different ways to potentially focally treat the prostate, to try to, for very small visible lesions, to try to focally treat the prostate and potentially avoid some of the side effects. You have to be the right candidate for that. It's not for everybody, and that's really important to know. So I do want to take a couple of minutes just to really just quickly touch on the prostate cancer outreach clinic that we've developed at Mass General Brigham. And it's a really important program that, we feel very strongly about. And the reason is that we know that disparities in prostate cancer exist. There are disparities by race, by socioeconomic status, by, urban communities and rural communities. And there's differences in rates of screening and detection, rates of use of different, testing techniques and imaging, and rates of treatment, differences in treatment rates and differences in outcomes. And so it's important to address that. We started the Prostate Cancer Outreach Clinic at Mass General Brigham in 2021. And again, it was actually our first combined clinical program between Brigham and Women's Hospital and Mass General, funded by MGB. And again, the goal is really to improve access to prostate cancer care. We have a community health worker and a project manager. They're right there, Denisha and Claudia. And we have community, have a community and clinical advocacy partner groups like, Faye at AdMeTech. And we really collaborate with at community outreach events, and also what we have called a PSA safety net to make sure that we're following up on PSA tests that have been done. These are some of the collaborators, including AdMeTech, and some of the events that we've participated in, which really have been, I think, a nice way for us to meet people in the community and have open conversations. So just to summarize, prostate cancer, we know screening is important to do with PSA. It helps treat men at earlier stages, and it reduces mortality. I went through the standard of care treatments and options for prostate cancer. And we hope that improvements in imaging will continue to advance care for our patients, and improving care for all of our patients, including the underserved, will maximize outcomes for, our populations across the state. So I really, thank you again for giving me the opportunity to share some thoughts and help, talk about what, I think is a very important subject, and really thrilled that you're taking the time to talk about this.
Dr. Feldman, thank you. I hope you stick around for the question and answer.
Oh, absolutely.
And I want to introduce Christine Deal Conrad, who's a doctor, PhD, MPH, and the other thing she'll explain to us, but she's the Associate Professor of Medicine at Harvard Medical School Division of Population Sciences, Department of Medical Oncology, Dana-Farber Cancer Institute, and Associate Professor of Nutrition in the Department of Nutrition at the T.H. Chang Harvard School of Public Health. And welcome to the crew, as we say. So Dr. Conrad, you have the floor.
Thank you so much. Thank you for the kind introduction. It's great to meet you all. Thank you all for joining in. I am also going to share screen. And as mentioned, I am also at Dana-Farber Cancer Institute. I'm an exercise physiologist by training. So I have the pleasure of sharing with you the goal and the mission of my research within a field that we actually call exercise oncology, which some of you may have not actually ever even heard of. So I'd be happy to actually share that, and especially in the context of prostate cancer. And everybody can see that okay?
Yep.
Great. Awesome, great. I'm also a proud resident of Cambridge. I've lived in the New England area now for 5 years, and I'm actually from Los Angeles originally. So surprisingly enough, there's many features of Cambridge that actually remind me of Los Angeles. So I'm thrilled to be here on that level as well. So I am going to hopefully try to convince you all that exercise is medicine for prostate cancer survivorship. Most of our work is focused on individuals who have already been diagnosed. And as I mentioned, also in the context of exercise. And I'd like to just first and foremost, to shout out to members of my lab and collaborators. And also, as you can imagine, my work is funded by different organizations, including the Prostate Cancer Foundation, Pfizer, Department of Defense, who've more recently funded a lot of our work in prostate cancer. In the short time that I have with you today, which will be less than 10 minutes here, I will talk to you about the different problems associated with prostate cancer that exercise can solve, using exercise as medicine, and then I'll actually share some exercise oncology trials in the Boston area that we have going on. Briefly, this is our research goal. Generally, what we see is what happens in the red dashed line is that different health outcomes tend to decline after diagnosis. potentially as a result of treatment toxicities in the context of prostate cancer. Androgen deprivation therapy is one such therapy that we can actually offset side effects with exercise with. And I'll get more into that shortly. Unfortunately, what you see in the dashed purple line is that there's obviously health disparities, and that individuals who are Black or Hispanic tend to have worsened health outcomes as a result of diagnosis and treatment side effects. So what we try to do is push those lines up towards that solid blue line with exercise at various phases throughout the treatment trajectory, so that we can hopefully improve quality of life in the long term. These side effects that I'm referring to are often referred to as causing accelerated aging. In other words, the diagnosis of cancer and the treatments tend to cause the aging process to speed up. So in individuals that have a history of cancer, they tend to accelerate different aging aspects such as muscle wasting, poor bone health, et cetera, which you see in the dashed blue line there, versus individuals who do not have a history of cancer who might progress through the aging process more slowly. So the solution that I'd like to convince you of is exercise. Exercise improves many health outcomes after treatment and even during treatment among cancer survivors, not just prostate cancer survivors. Improves quality of life, anxiety, depression, fatigue, physical function, fitness. I can go on, which I will in just a bit. And because there is such a plethora of research published in this area now, as this is not a new field of research, we have exercise recommendations for cancer survivors, and those include aerobic exercise 3 times per week at about 30 minutes per session of a moderate intensity. Moderate intensity would be exercising at a pace where you are out of breath or have a difficult time carrying a conversation. And lifting weights or engaging in resistance exercise 2 to 3 times per week at about 30 minutes per session and really focusing on large muscle groups. Now, importantly, also exercise oncology within prostate cancer has been well studied. There's hundreds and hundreds of studies to demonstrate the benefits of exercise in this population. I'll start from the top right and go counterclockwise, reducing fatigue, improving joint range of motion, potentially treatment tolerance or how one moves through treatment, improves muscle conditions, bone density, reverses deconditioning, could improve chances of survival, quality of life, reduces recurrence, balance, pelvic floor function, immune function, possibly treatment efficacy, aerobic capacity or physical fitness, mood, chemo brain, you name it. This is almost every body system covered here, and an exercise is actually able to improve these outcomes. Minimal evidence is around treatment tolerance and treatment efficacy, which is why those have a little gold star there. So of relevance to prostate cancer and urologic cancers, I'll just show a little bit of data here and then I'll go into the work that I've done. But really, again, just to convince you of how beneficial exercise can be. So we actually know just all the way beginning from perhaps time of diagnosis up to surgery, we know that pre-surgical exercise, often called prehabilitation, is beneficial. This is a study just overviewing that pelvic floor muscle training actually improved incontinence. Following surgery, exercise reduced hospital stays and post-surgical complications. And this averaged about 5 fewer days in the hospital and a 55% reduction in complications. And this is just a conglomerate of exercise data from over 18 studies, including prostate cancer, but also lung, breast, bladder, and other multiple sites. And this was exercise performed as little as 1 day before surgery to 3 weeks. Exercise during therapy, such as chemotherapy, radiation therapy, et cetera, is also beneficial. This is just data to show that exercising during therapy, not only is it safe and feasible, but it can improve muscle strength and lean body mass. On average, improvements in strength were about 26 kilos, so over 50 pounds in gains in strength, and improvements in almost 1 kilogram of lean body mass, which may not seem substantial, but it's actually really, really difficult to build muscle, period, regardless of cancer, regardless of being on treatment. So the fact that there were some gains in muscle is pretty profound. This is also a conglomeration of data from 13 studies in prostate and breast cancer with an average of 15 weeks of exercise during treatment. And this is a question I get asked a lot. Does exercise actually improve mortality? I would like to share this particular study, especially when I'm talking about prostate cancer, because resistance exercise is really critical. And in this study is just simply a yes or no question to ask to over 2,800 patients. Those who participated in exercise had a 33% lower risk of death. And this was, again, just by self-report. Some of you may have heard the news in the press of the newly published challenge trial, which was presented a few weeks ago at a major cancer conference, which also demonstrated that participating in exercise improved mortality outcomes. That was specifically in colon cancer. So now here's the work that we focus on. We like to focus quite a bit on side effects of androgen deprivation therapy, which, as shown here, will reduce testosterone and help to limit prostate tumor growth. Is a very common mainstay of prostate cancer treatment, but there's many complications: reductions in lean mass or muscle mass, increased fat, reductions in physical function and quality of life. So we did a study with only resistance exercise for 12 weeks, and we had patients come to our exercise lab, and we found that with this 12 weeks of resistance exercise, we were able to significantly improve lean mass in this population. The main data that I'm speaking of is on the right-hand side, where you can just simply see the significant data in red in the exercise group. Individuals in the exercise group, also about 38% of them had what's called sarcopenia at baseline, which is low muscle mass. And at the end of the 12 weeks, only 15% had sarcopenia. So again, we were able to show in a relatively short period of time that we can improve muscle mass. In that same study, we also showed improvements in quality of life. We used a tool specific to prostate cancer called the FACT-P. We saw trends for improvements in fatigue and depression, but no significance. And I'm going quite fast just to stay on time here. So that's just a little sprinkling of our work to date. I could really go on and on about that, but for interest of time, I wanted to share the 3 trials that we have going on now at the Dana-Farber with prostate cancer. We have the POWER trial, the THRIVE trial, and the FIERCE trial. Obviously, you can tell these are all named with very powerful, positive, uplifting trial names, because we feel that is the effect that exercise has. And I'll talk about each of these in detail. Specifically here and relevant, I think, to this audience, when I first started getting into work with prostate cancer, as I mentioned, there's hundreds and hundreds of exercise studies with prostate cancer. Prior to getting the POWER trial funded, there had actually only been one study specifically for Black men with prostate cancer. And so I was inspired to design the POWER trial, which is using exercise to enhance cardiovascular health among Black men who've been diagnosed with prostate cancer and are using androgen deprivation therapy to really offset those side effects of androgen deprivation therapy. This is actually a fairly large pilot study. We're hoping to get 62 patients on trial, and we're close to 40 to date now. This is led by myself at Dana-Farber, and then we also work closely with Beth Israel, which, as many of you may know, is right across the street from Dana-Farber. And again, we're really trying to offset potential side effects of androgen deprivation therapy on cardiovascular disease, which is a main cause of death following diagnosis of prostate cancer. Individuals receive supervised 3 times per week aerobic and resistance exercise with the equipment sent to their home. And it is virtually supervised using Zoom over a device. And actually now, because we have so many patients on trial, we're actually developing multiple proposals using the data we have to date to apply to larger grants for what we would call a large phase 3 trial to the NIH Department of Defense and also to the Prostate Cancer Foundation. And I'll just wrap up with 2 more trials that we have really quickly here, as I know I'm getting close to my time. The THRIVE trial is actually the first exercise trial to actually use exercise to mitigate or to improve exercise in Hispanic and Black populations. This is also virtually supervised, but this is for individuals actively going through chemotherapy. And they receive either exercise supervised or unsupervised, and it's randomized to determine who will do so. And again, this is all in an effort to gather preliminary evidence to then use to design a larger trial, again, in hopes to target comorbid conditions such as heart disease. And then lastly, another exciting trial is what we call the FIERCE trial. This is actually for individuals who've been diagnosed with metastatic prostate cancer. which is a more advanced severe diagnosis with prostate cancer. And these individuals actually are asked to come to our lab to exercise because we're specifically trying to provide an appropriate stimulus to the muscle to prevent frailty and sarcopenia. And we need sort of the larger, heavier based equipment that we have in our lab in order to do so. We also ask patients to volunteer for muscle biopsies if they're willing, so that we're able to actually look at different pathways in the muscle related to muscle growth. And we're also looking at biochemical progression by looking at prostate cancer cell lines. And this is also a third ongoing trial here. So here's just a quick overview. All three of these trials are recruiting. And perhaps most importantly, we have our contact information here for anybody who might be interested or knows somebody who might be interested. My research coordinator who works on these trials is Jocelyn Greer. Their information is here. My information is here as well. And I also like to plug an organization that some of you may or may not know about to just promote activity within the community, which is referred to as Black Men Run Boston. And I'm also happy to answer questions there with that and connect people to that organization as well. And with that, I thank you all for your time, and I will also stay on for questions.
Thank you. Thank you. Thank you. I actually know some folks who are in the Black Man Run Project, good friends of mine here in Cambridge. I'd like to introduce Dr. Stern, who's the president and CEO of AdMeTech Foundation. And while I'm here, I might as well thank her for creating this collaboration between the NAACP and her organization. It's been a great 3-year ride, and I look forward to more of our time together helping to talk about the important issue of prostate cancer. Dr. Stern, the floor is yours.
Thank you so much, Richard. It's a pleasure to be here. President Reeves, Richard, Aisha, I am very, very grateful for your partnership. I also want to thank Adam, who showed up at this event, as you can see, still in operating group attire. And I want to congratulate Christina for her exciting work. Almost all of my career, we have been so historically focused on improving patients' ability to survive, improving mortality, reducing side effects. It's very exciting for me to see work that goes far beyond that. And actually, it is focused on well-being of prostate cancer survivor and their ability to thrive. It's a very exciting work. Actually, it's a presentation that was suggested by President Reeves based on his own experience, and it's very exciting for me to see. My presentation will focus on a little bit of AdMeTech history and a lot about AdMeTech programs, including our public awareness, but in particularly our program in prostate, our program, which is called Prostate Cancer Equity Resource Project, expedites access of Massachusetts men to the best clinical experts and to the kind of resources Christina just discussed. And it is we are honored that Cambridge NAACP, under leadership of people present here, send us a few men we were able to make sure who had great prostate cancer care, including President Reeves. I usually like pre-record my presentations because I've dealt with so many technical problems. So Emma will start my video. My name is Faina Stern. I'm a physician and president of the AdMeTech Foundation, a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. My gratitude to the Cambridge NAACP for making this third annual joint prostate cancer awareness event possible. Drs. Feldman and Jill Conright reviewed recent advances in screening, diagnosis, and treatment. The focus of my talk is on the AdMeTech Foundation history and our prostate cancer program, established to lead these cutting-edge advances in patient care, to bring them to Massachusetts men and eliminate health disparities.
History of AdMeTech Foundation and its programs is closely tied with my own professional and personal history. Since 1990, I was head of diagnostic imaging research branch at the National Cancer Institute. In this position, I was leading development of national and international policy and related strategy and programs for the National Institutes of Health, NIH, Department of Health and Human Services, and US federal government. Our priority focus was on the advancement of breast cancer imaging. We created digital mammography, breast MRI, advanced ultrasound, and molecular imaging for improved patient care. We also work on teleradiology for image transmission so that we could bring world-class expertise to underserved rural and remote communities. As of early 90s, most women had blind biopsies. Precision imaging made it possible to see where suspected tumors were located and develop stereotactic biopsies where biopsy needles are guided with precision to suspicious areas. As of early 90s, women with breast cancer have radical surgery or mastectomy, where the entire breast is removed. A procedure performed in operating rooms causing physical, emotional trauma, pain, suffering, and deformity of women's bodies. Precision imaging made it possible to proceed with minimally invasive surgery or lumpectomy, where we identify and remove only a part of the breast tissue containing tumors. These minimally invasive procedures are performed in outpatient clinics with minimal complications, pain, suffering, and costs. As of early 90s, many women, particularly Black women, were diagnosed with breast cancer in more advanced stages and were more likely to die. With digital mammography and MRI, all women are more likely to have early detection of breast cancer, critical for saving lives. Today, Black women have a nearly equal chance of dying compared to white women in many communities, particularly in a state like Massachusetts with its universal access to care. In 1996, while our breast cancer programs were well underway at NCI and NIH, I brought together the key leaders of government, medicine, and industry to outline new strategic priorities. This expert recommended prostate cancer as the next priority focus for several reasons. First, prostate cancer is the most common major internal cancer among men. It is as common among men as breast cancer is among women. Prostate cancer strikes 1 in 8 men. Breast cancer strikes 1 in 8 women. Second, prostate cancer screening with blood test PSA was successful in identifying men at risk of losing their lives and in reducing mortality or the likelihood of men dying of prostate cancer. However, men did not have accurate diagnostic tools that would make it possible to sort out if an abnormal screening result is due to false alarm or due to a life-threatening prostate cancer. With no accurate diagnostic tools, many men had either insufficient diagnosis and treatment of aggressive prostate cancer with dangerous consequences, or on the other side of the spectrum, they had overdiagnosis and overtreatment of benign and harmless prostate cancer, leading to unnecessary invasive procedures with related life-altering complications and costs. Third, treatment of prostate cancer, such as radical surgery, was highly invasive and traumatic, leading to a prolonged hospitalization, difficult recovery, and the unacceptable level of life-altering complications. Fourth, prostate cancer is a leading health disparity. Black men are 2.5 times more likely to die compared to white men. We did not see this level of disparities in breast cancer even early in my career, in the 80s and 90s. Finally, In sharp contrast to women with breast cancer, men did not have accurate imaging, leading to blind biopsies and treatment. Our work in breast cancer imaging created a blueprint for transforming prostate cancer care and eliminating health disparities. And about the same time in 1996, I had a personal experience that left me shaken. A leading clinical expert in Massachusetts, chosen by me, saw my father and determined that he had a benign and common prostate condition. However, when my dad had an invasive procedure for this condition, he was found to have prostate cancer. I was shocked that a leading expert in a world-leading hospital did not have diagnostic tools to make accurate clinical diagnosis. This experience transformed my professional interest in prostate cancer into a personal mission to improve early detection and treatment of this disease for all men and to reduce health disparities in Black men. If we made a difference for women with breast cancer, we could make a difference for men with prostate cancer. I organized other leaders of medicine, and we approached NCI and NIH, key leaders, in the hope to see an increased government investment in prostate cancer research. Unfortunately, in spite of our joint track record and a year-long effort, we did not succeed in convincing federal government. Consequently, by late 1997, we established AdMeTech Foundation with the mission to end blind patient care and create the future of image-guided, minimally invasive diagnosis and treatment. Since 1997, we have been leading a pioneering research that resulted in creating precision MRI, molecular imaging, and other diagnostic tools that transformed prostate cancer care. In 2005, we initiated a large-scale national public awareness campaign, where is Manogram, prostate imaging for men. In 2009, we had the first annual Prostate Cancer Awareness Day in Massachusetts State House and proceeded to create a new model in public education. In 2011, as the result of our advocacy, Massachusetts legislature had set up a historic precedent by recognizing prostate cancer as the central healthcare problem in men, a leading health disparity and public health priority. By 2013, Massachusetts legislature established a prostate cancer program. It started as a research project that was seminal in making MRI as standard in patient care. Since 2014, we expanded our efforts in public awareness, reaching countless men. In 2016, we established annual global summit on precision diagnosis and treatment of prostate cancer. And in 2021, we had launched Prostate Cancer Equity Resource Project. Our statewide program in prostate cancer created a Massachusetts model of national and global leadership in public awareness, medical education, research, and health equity. AdMeTech is leading this program in cooperation with multiple organizations, including but not limited to American Cancer Society, leading clinical experts, and branches of NAACP and Latino Health Insurance Program located across the state. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. The centerpiece of AdMeTech's medical education is annual global summit on precision diagnosis and treatment of prostate cancer. Our summit has been recognized as a seminal event shaping the state-of-the-art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. There is not a corner of the world that has not been represented at this event. The latest 8th annual conference took place in October 2024. It was interesting to hear at the last summit from multiple experts that of all diagnostic tools, diagnostic imaging had become the game changer for men, resulting in improved diagnosis and treatment of life-threatening prostate cancer, while decreasing unnecessary biopsy and treatment in countless men. For example, in this slide, MRI shows prostate cancer lesions and guides biopsy needles with precision. AdMeTech has led research and development and large-scale implementation of prostate MRI since 1998. In 2013, Massachusetts legislature funded clinical trial of prostate MRI, which produced groundbreaking data that were presented at the summit 2016. 6 months later, by early 2017, MRI was recommended as the new standard of patient care prior to biopsy and treatment. Similar to breast cancer, precision imaging paved the way not only for precision biopsy, but for image-guided, minimally invasive treatment for prostate cancer. We call these procedures focal because imaging makes it possible to treat only cancer while sparing normal prostate tissue. Similarly to lumpectomy, which replaced radical mastectomy in most women, these minimally invasive focal procedures can be performed in outpatient clinics with minimal complications, discomfort, and costs. And they are expected to replace radical surgery in many men. Our summit highlighted the importance of MRI in Black men who are likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard blind biopsies performed without accurate imaging. More recently, molecular imaging has been shown to play an important role in staging of prostate cancer, including presence of metastatic spread and detecting return of prostate cancer after treatment. For example, molecular imaging with PSMA has become available at the Dana-Farber Institute since August 2021. On the left, we can see regular bone scan, which does not show metastatic disease. On the right, however, molecular imaging with PSMA shows multiple metastases. This information is critical for selecting appropriate treatment. We are proud to have led research and development of molecular imaging since 1997. This made it possible for us to help Mr. Reeves get access to molecular imaging in early 2021 in New York before it became available in Massachusetts. Our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Resource Project in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care for all. More recently, experts from Beth Israel Lahey joined us. Supporting organizations include Latino Health Insurance Program and multiple NAACP branches located across the state. Any Massachusetts man age 40 and older is welcome to participate. Our priority focus is on Black, Hispanic, and Latino men who are at high risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and to support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion in person or virtual visits. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer longer term, to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined process of patient referral and care, reflecting how doctors involved in this program would like to take care of our families and friends. This process consists of several components. First, AdMeTech Foundation's team collects basic information and match individual patients' needs with the appropriate state's experts for clinical care. Second, a clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, financial and insurance assistance if needed. Third, if an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as, for example, additional testing or treatment. I am grateful to Mr. Reeves for sharing his personal experience with Prostate Cancer Equity Project. I'd like to provide a few additional examples of how PCE Resource Project has been making a difference. In December 2024, Martha's Vineyard, NAACP, asked us to help an older Black man who expressed a lot of confusion and concerns about his care. AdMeTech staff contacted Dr. David Einstein at Beth Israel Lahey, who agreed to provide a second opinion. In February 2025, this man and his wife had a visit with Dr. Einstein, who provided a clinical consultation and contacted the regional clinical care team to ensure a coordinated approach. In March 2025, patient and his wife described that as a direct result of Dr. Einstein's consultation, they understood their situation for the first time and became clear about the next steps. The second example involves George Brickhouse, who in December 2022 took part in the virtual meeting of the Prostate Cancer Equity Resource organized by Steve Bernard of Brockton NAACP. During that meeting, George expressed the lack of trust in his care and difficulties in scheduling prostate MRI recommended by his doctor. I got concerned, and after the meeting, contacted Steve and asked him to explore with George if he would be interested in joining our resource. In early 2023, George contacted me, and I suggested for him to consult with Dr. Kwok Ding Tring at Mass General Brigham, who can assure the best of class care, including high quality MRI. George has been so happy with his care at MGB that he became an advocate for our PCE resource. In late 2024, Dr. Tring moved to Pennsylvania due to academic promotion. In March 2025, per George's request, we referred him to Dr. Adam Feldman, a leading clinical expert at Mass General Brigham, who is participating in this event. Emma Coyer serves as a manager of the Prostate Cancer Equity Program. Emma is assisted by Erin Roberts, program coordinator, Craig McClay, patient educator, and other members of the AdMeTech Foundation's team. We serve as your individual patient care advocates. When you come to us, Emma will work with you, our team, Marjana Brigham, UMass, Beth Israel, and other clinical partners to expedite medical visits and address any needs you may have. Together with clinical experts, we empower each man to make informed choices in patient care that are right for him before and after screening, biopsy, and treatment. If you have any questions or need assistance, please contact Emma by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention.
Well, thank you, Dr. Stern. And I just want to, have a personal testament to say AdMeTech has helped one of my family members and guided them through their treatment. I want to jump in just to a few questions, particularly while we have Dr. Feldman and others on. So I'm going to ask you two questions, Dr. Feldman, just in the sake of time. We got about 10 minutes. So one is understanding the controversy that you spoke about, and I know from my own experience with the PSA. Can you just give us your 60-second advice if one is at their PCP and they're, getting their annual physical and they fit within the range that you talked about in terms of risk factor? And then second, I think a very important thing, and Ken would tell you this, that in the circles I'm in with men, the biggest conversations are happening about the post diagnosis and treatment plan as it relates to sexual function particularly, but also maybe Christina, you can talk a little bit about what it means for the limited or not activity. I know that I'm with a lot of men and a lot of organizations that I'm in, and I can't tell you how intrigued these men are to hear about what you can and cannot do, what you used to be able to do and might not happen, and how we can pull things back together. And I say it tongue-in-cheek laughing, but these are some real conversations, and I think it'd be good if you could lend some understanding to what life might be after. And I know it's not for everybody the same, but these are the conversations I'm in. So one is about just your general advice on the PSA, understanding that controversy. And the second one is kind of the questions that are naturally come up around erectile function and even just functioning as a post-diagnosed and treated prostate cancer patient or survivor.
Yeah, well, thank you for the question. I think that's a great one. In terms of talking to your primary care provider about it, I think it's important to, if they're not already discussing it, to ask about, doing a PSA blood test. We know that, especially if you have a family history of prostate cancer in a first-degree relative, that's really important. Or not only prostate cancer, but also a family history of, there are some other, breast cancer, colon cancer, pancreatic cancer, melanoma, and ovarian cancer. So these are cancers that are actually associated genetically, potentially, with prostate cancer. And men of color also, we know have a higher risk. So that in itself is a reason to ask about testing. And a baseline test at age 40, we've seen, can help predict risk of, prostate cancer death. So that's important. And then, to look at, what are the results, and if there's any concern or, elevation based on age, then, that would indicate a referral. And so we use an age-based approach. If men have, who are in their 50s have a PSA that's, above 2, they should probably be evaluated. If men who, a man who's 80, then, that's a question if they should have a PSA from the start. But then I've had a lot of men who are 80 and really healthy and come in and they're asking me about President Biden and should they have gotten a PSA? So it also depends on your health. Those are important, those are really important things to talk about. So I think
real quick, can you just define to us, because you made you said a term that I didn't know. What's free PSA mean, just for the audience?
So percent free PSA is there's total PSA and then there's free PSA. And that's a test that we will use in men who have a PSA that's elevated, that's above 2 or 2.5. And so we'll use that. That's a little different. It's not ordered when it's just a screening PSA. When it's a screening PSA, it's just the total PSA value. Okay. But percent free PSA is so some of the protein, that the PSA is a protein, some of it is sort of freely floating in the bloodstream, some of it's bound to other proteins. And there's evidence that if you have a lower percentage of free PSA, that actually you can have a slightly higher risk of having prostate cancer. So that's what that is.
Thank you. So to the second question, and then I want to also have Christina jump in, but to the second question, just give us globally your advice for people who are asking all of those questions about post-procedure or post-diagnosis treatment around the sexual function and general function. And then Christina, when Dr. Feldman finishes, if you can just tell us about any limitations that may happen. One thing you spoke about, Christina, was the fact that sometimes men are already dealing with other comorbidities and other things. So for your program, there's some limitations maybe, but if Dr. Feldman, you could start about what I would say, and Ken Reeves would attest, the most talked about thing from the prostate cancer survivors I know is the regaining their sexual function, and what your advice is around that. And then we'll jump to Christina on the other question.
So that's a really important thing to talk about, an important thing for, as men are thinking about different treatment options. So I mentioned the prostate and what are called the seminal vesicles, which are little glands that come up the prostate. They make the ejaculate fluid. So that after treatment, after surgery, that goes away. And then after radiation, that tends to diminish over time. So that's one aspect of sexual function, which is important to talk about with, ejaculation. Actually, men can still have the sensation of orgasm. They can, nothing comes out, but they can still have that. Then there's the aspect of the part of sexual function, which is the ability to have an erection. Okay. And so that's a little different mechanism. So the nerves that initiate erections, they're actually run right alongside the prostate. And after surgery, often, probably most times in surgery, many times in surgery, we will spare those nerves, but even just moving them out of the way, they stop working for a period of time. And so then we hope that men, and after surgery, erections typically go away right after surgery. And that's important to know. And so one of the things that we try to work with men on is, might sound silly, but it's called penile rehabilitation. And it's basically taking medications like Cialis or Viagra regularly, sometimes using a vacuum device regularly, all to try to help improve the recovery of erections after surgery. And what that does is it actually helps to improve the routine blood flow to the erectile tissues to try to prevent some of the changes that occur after surgery and that lead to some long-term erectile dysfunctions. And I think one of the most important things I tell patients when I'm talking to them about this, pardon my voice, sorry, is one of the most important things I tell them is that it's really important to have an open conversation, about the differences and changes in sexual function. There are other ways to try to help you get erections, and there are other ways to help you get that part of your life back. Where there's some injectable therapies, there are other things that we can do to help you. And so it's really important to have an open conversation about it. And, to know that I wouldn't avoid, being evaluated, avoid treatment because of that, because there are a lot of ways that we can help you. And it's just really having open conversations about it.
Thank you, Dr. Feldman. And just quickly, I think that this is critically important because for a man, this topic, they would be having serious consideration on whether or not they'd rather go to another place or have these procedures done. I have to tell you, as a man and a Black man and being amongst them, this is a serious thing. Christina, I know you have your questions, but I just want to load up in the sense of time. Also, Dr. Stern. Dr. Stern, the question to you after Christina goes on is, I want you to just talk about the holistic approach that your organization has around, the treatment, in that, this is really a family thing, right? The women, the sisters, this is all part of the thing. And oftentimes the women are left out of this, and they're usually, for the men I know, they're the main support system. So I want to let Christina go, Dr. Conright, but then I want you, Dr. Stern, to talk about the holistic approach that you have with your project. So Dr. Conright, why don't you go? And your question is around any limitations that you may find, understanding that sometimes these men that you get at the time you get them may have comorbidities or other health issues that may not allow them to thrive necessarily, or maybe it does allow them to thrive. If you could just tell us more about how you go about and what your approach is to that piece of the puzzle.
Sure, absolutely. We rarely exclude any individuals from our trial based on certain limitations, because there's just so many ways you can change exercise to accommodate individuals' personal health history, potential comorbid conditions, et cetera. The only time I can think of, I guess there'd be two occasions, if there's maybe some type of really chronic joint pain that might need to be seen by orthopedics, that would potentially, like chronic hip or knee pain that actually is so exacerbated that it would be incredibly painful to exercise. And then that would then be a case where it wouldn't be appropriate for us to prescribe them exercise. They would need an orthopedist and then potentially physical therapy. That rarely happens, though. People are usually already so far deep into getting that type of treatment. And then second would just be any type of unmanaged cardiovascular or cardiorespiratory issue that is not already being seen, or they're not already being taken care of under the care of a physician. And then we would simply work with their primary care physician in order to make sure we're safely prescribing exercise in collaboration with what their physician might already have in mind. If so, this would really only come up with individuals who may have had a recent heart event and they might need cardiac rehab prior to actually coming to join us. Otherwise, we can really take all comers, and even if they're not coming to our studies, even if they're just engaging in exercise on their own, it's really just understanding the limitations they might be aware of and have, and then taking it slow and being safe, and listening to their body so that they don't induce an injury of whatnot. But there's always ways to prescribe exercise safely to many people.
And thank you. Just really quickly before I go to Dr. Stratton, and is there a nutrition component as well to your physical activity component, the power stuff?
Actually, not in the 3 studies that I talked about today, but we have a new trial that I failed to mention called the Vitality Trial, which is actually for prostate cancer survivors over the age of 65 and their support person. So it's what we call a dyadic intervention. It's a partnership, and it includes exercise intervention and a Mediterranean diet intervention as well. So that is a new trial that we also have. So some of our research does and some doesn't, to answer your question.
Thank you. And Dr. Stern, as you answer the question about the support system, particularly the women who seem to be the primary support system, and most of, not all of the scenarios, obviously, when I talk to people, it could be whoever their significant partner is. But also, could you just talk a little bit about, and I take this from understanding my family member who you helped, personal thing, but can you talk about how you guys at AdMeTech help with that sort of health navigation piece? And my own men's health program, Ken knows this well, that health navigation, literally holding someone's hand through the process, is a major way to get people to not only comply, but to have another level of support as they go through what I'm going to say is, in some ways, a very traumatic time for them. Anytime you hear the big C, no matter if it's skin cancer, whatever it is, people reflect differently on their mortality. So could you just add that, as, to the support that AdMeTech gives around the sort of health navigation while they're going through treatments and referrals and biopsies and all the stuff that comes with this? Dr. Stern.
We leverage several historic strengths of our organization. One is outstanding network of the best experts in prostate cancer in the state and beyond. By now, people outside of the state started coming to us for help. Secondly, we leverage trust that we built with Black and Hispanic community in Massachusetts. We also learned in relationships we built. So if you look at, Richard, if you look at the statewide situation, according to the best data we have, Black men are 22% less likely compared to white men to follow their physician's recommendation for treatment. Even greater percentage of Black men fail to comply with recommendation for biopsy. We do not see it in our program because we built such a infrastructure of support and we built such a safe environment. Let me give you an example. Sometimes men get out of communication. They get scared. They get extremely upset about complications. We do not wait for men to come to us. We check in with men to make sure that they are okay and they have no concerns. If they have concerns, we will intervene. We will intervene with clinical colleagues. We will intervene with patient clinical navigators at academic institutions to make sure that men are not falling through the cracks. Secondly, some men go out of communication. They get scared. So if we cannot get in touch with them, we go to community leaders who are their friends, who are trusted by them. And we had situations when we were concerned men were recommended biopsy and treatment, and they would not communicate. They got scared. So we would go back to their family members that we knew. We went back to community leaders in order to re-engage them and to restore communications and bring them back into the healthcare, into the arena of healthcare interventions they critically need. So we are leveraging once again, we are leveraging incredible network of clinical experts. We are leveraging community trust, and we are leveraging community relationships. And therefore, we do not have disparities in compliance with recommendations, the kind that the state sees.
Thank you. I want to just, before I go to Dr. Feldman, I'm going to indulge us for maybe 5 more minutes if I could keep you. So my uncle, we had through one of my things from actually, I think it was Beth Israel, we had a prostate cancer screening van that came about 12 years ago. And he just took a PSA and found out literally on the van on an event that I invited him to that his had an elevated PSA. And to Dr. Stern's point, he waited. Of course, because I was a steward of the information, it was my thing. I had to sit him down on his porch and say, you got to go see somebody and follow up. So I think I'm so appreciative, Dr. Stern, of you understanding that. To Dr. Feldman, 2 quick questions. One is understanding, and I'll just say my experience through the controversy and the time I've been doing this 23 years, I have seen the advancement of the prostate sort of cancer treatment continuum, so that, 15 years ago, the use of the MRI was a lot less prevalent. I don't know if it was insurance or other things, but can you tell us kind of where you see this going as it relates to the cutting edge stuff that you may be seeing? And then the second piece is, one study came out in Cambridge, Mass, I think it was about 5 years ago, maybe 4, where men of color in Cambridge, for whatever reason, were being diagnosed in the later stage. Could have been because of the connection to primary care. I don't know what the medical rationale is, but I know the study basically said that compared to white men, men of color were at a later stage being diagnosed. So if you could just speak to those 2 perspectives, it would be helpful, I think, for the audience.
Yeah. So the first question, that you asked about, it just remind me, it was
around like the evolution of the technology.
Oh yeah.
50 years ago, the MRI was like, you had to know what you were doing. Now it seems like it's standard procedure. I'm just thinking about where we're going moving forward in your eyes?
So I'll just say in terms of, MRI has been a big advance. And actually the reason, we started using MRI in men who had had a prior negative biopsy. And those were the people who we started using it in. And, in men who already were diagnosed with prostate cancer, where we're trying to sort of understand, what's the amount of prostate cancer they have and the staging. And then we started using it. There was a study that looked at using it for, just the early detection and even pre-biopsy. So that's been a big advance. I would say one of the things that we want to try to do is to make imaging better. Again, my hope is that, and I don't know if it's going to be used for detection because you have to think about the cost of using it for everybody, but maybe combining the PET scan with MRI. And that's what I'm hoping, actually, that the study that we're doing, which will help to improve the effectiveness of imaging of prostate cancer. The other thing that I actually think will help just with MRI is, I talked about the variation in the sort of efficacy of the test, or the effect of the accuracy of the test. And there's some variation amongst centers, amongst, radiologists and how they're interpreting the images. So actually, one of the things that we really hope is that using AI to help interpret the images will do two things. One, help us to better interpret these images than the human eye can potentially. And then number two, help to standardize the way they're interpreted so that we have more more consistency in how these tests are being interpreted. And so, we might be able to actually get more out of the current imaging that we're doing so that we're not, all absolutely going to increase costs for the entire populations.
Thank you, Doctor. Yep, go ahead.
Yeah. So, and then the second question I think you had was about, men in Cambridge. I don't have a great answer for that. I don't actually know the study. It'd be great to see it. I'd love it if you'd send it to me.
It was an older study just looking at when they were diagnosed. So it was like they just seen there was a disparity in diagnosis. I just wanted to know if there was something that you were seeing in your own practice. If not, that's okay.
Well, I will just comment about there are a lot of people, good, smart people who are trying to tease out the differences and disparities and the causes of disparities, and whether it's really socioeconomic or some, underlying genetic reasons. And there's probably a combination of both. One of our former fellows, who is actually originally from Nigeria, lives in Chicago, and now is back in practice in Chicago. He does research looking at comparing the genetics of men, Black men in the U.S. compared to men who are in Nigeria, and trying to understand, because actually that was in the area that he, near where he grew up, was one of the areas where there was one of the main ports in the slave trade. And so where I think it was maybe, 60% of the men, of men who came to the US, at that time came through that port. So he's looking at comparing the genetic profiling and the underlying genetics of these men and comparing it to men who now live here. And it's really interesting work. So it's a hard question to answer.
Yeah, really quickly, Dr. Stern, before the last question to you, and then we'll close. Can you just tell us a little bit about how your organization has been helpful, particularly if people run into insurance issues or other things? It seems like in most cases, I would just use the Cambridge scenario, that many men that I deal with, usually at this point, insurance, whether it's some mass health or other things, seems to not necessarily be the barrier. However, that could be different in different scenarios. But can you tell us how you all make sure that men can get access to high quality care regardless of the insurance situation?
Actually, there is a twofold approach that we have taken. Secondly, first of all, major academic hospitals like Mass General Brigham, like UMass, like Beth Israel, they have incredible resources in finding their appropriate insurance mechanism for men if you come across the right representatives of this organization. So the role of social worker, patient navigator in clinical institution cannot be overstated. And our first my first conversation with Dr. Feldman and Dr. Trink, who were our regional partners, clinical partners in prostate cancer equity program, was actually to request a patient navigator who will be that contact for men, a single contact for all the issues, insurance, other financial issues, transportation, etc., etc. So men will not be bounced about from one department to another and get very frustrated and will be lost to follow-up. So this is, first of all, it's dealing with the best utilization of resources that already exist. Secondly, we specifically chose for our program Dr. Feldman, Dr. Trink, who was participated in our first event with Cambridge, many others at UMass and Beth Israel, physicians who are completely, utterly dedicated and passionate about eliminating health disparity. When you have a passion and commitment, you have a way of solving problems. I would never forget when my father needed a urologic consultation, I requested Dr. Feldman, and my father and I shared the GP, and my GP said, you cannot get an appointment with Dr. Feldman. It will take you 6 months to see him. Of course, I went to Adam, and Adam saw him within a matter of 10 days. And when I saw that, my impression was, if I asked Adam, who did it for my father, why can't I ask Adam, who I know is passionate about eliminating health disparities, to help Black patients? And Adam and every physician on our clinical team made sure that they made our patients their priority. Our patients do not wait 6 months for an appointment. Our patients wait 2-3 weeks for an appointment, occasionally 3-4 weeks. So selecting the right passionate clinician and selecting institutions that have resources that can be utilized in an effective way with the appropriate team.
Thank you. Dr. Carmike, just quickly, does your program have a insurance or financial, any obstacles that you found, or you a free program? Can you just explain how you bring people in and what the financial ramifications, whether insurance covers it, or how does that work for you?
Yeah, so all of our trials are funded by some type of sponsor that covers the cost of the research. And then in general, we will try to provide some type of additional incentive or compensation for efforts and time to come to the Dana-Farber, because we know that can be quite a burden sometimes, depending on, of course, traffic and transportation limitations. Unfortunately, to date in the United States, exercise and exercise medicine is not reimbursable through insurance. But myself and many colleagues do this research in hopes that one day that will change.
Thank you. So I just want to say thank you to our partners, the doctors who joined us tonight, obviously to our partners in this important fight to help men live healthier lives and to also improve the lives of people, particularly men, obviously, who are diagnosed or treated for prostate cancer. And I just want to thank President Reeves and the other members of the AdMeTech team, as well as the NAACP, Thomas and Emma and Aisha and Steve and all of those who had a part of this planning. And I look forward to the next time we're together talking about this most important issue. So for tonight, we're signing off, and I hope that you all are well and have a great weekend.